So in the previous part, we have stopped at this question. So let's see this. A 30-year-old woman, 24 weeks pregnant, presents with palpitation and dyspnea. She has a history of rheumatic mitral stenosis. Now her pulse is irregular with a ventricular rate of 140. Blood pressure is stable, no features of heart failure. ECG confirms AF. So this is a case of a pregnant lady, 24 weeks, history of MS, now with AF. Okay, what is the next best step in management? So you think about AF in general, not just in pregnant ladies in general. What are the guidelines? If it is AF unstable, you go for cardioversion. If it is AF acute and the patient is stable, again you can go for rhythm conversion by giving some drugs like MRCP. But if it's a chronic AF means what? More than 48 hours, or the onset is not known, then you have to always rule out thrombus, because AF can predispose to the formation of thrombus, which can then embolize, can lead to stroke and other events like mesenteric ischemia and everything. So you have to rule out thrombus. In order to rule out thrombus, you have to do an echocardiography, right? So that is what the guideline says. And in chronic AF, your main management becomes rate control rather than rhythm conversion, right? So that is the thing. Start warfarin immediately. No, warfarin not recommended during pregnancy. And if at all it has to be started based on the Chartu-DS2 VAS score, you have to first see the score, right? Perform trans-esophageal echocardiography. That is the thing, to rule out thrombus. Electrical cardioversion without anticoagulation. This again would be problematic. If suppose there was a thrombus, it would embolize once you give cardioversion, and it's not indicated also because the patient is now stable. Defer treatment until delivery? No, you have to treat. So you have to perform TE to look for left atrial thrombus. Question: a 24-year-old man presents with fever, malaise, nausea, anorexia for 5 days, followed by yellowish discoloration of eyes and dark urine. No history of alcohol intake or drug use. So this is a case of fever and jaundice, right? On examination, mild hepatomegaly, no splenomegaly. AST is 950, ALT is 1200. Bilirubin is 7 and predominantly conjugated. ALP is mildly elevated, INR is 1.1. So this is a case of jaundice, or this is a case of jaundice, and it can be hepatitis. It can be any kind of hepatitis like alcoholic, viral hepatitis, right? So there are 3 types of jaundice, right? It's obstructive jaundice, hepatocellular jaundice, and hemolytic jaundice. How do you differentiate that? Hemolytic jaundice is due to increase in hemolysis. That means more of the RBCs would be broken down, and unconjugated bilirubin would be high, right? Then, if it is hepatocellular jaundice, both conjugated and unconjugated can be high. Your AST, ALT can be elevated, right? The INR can be deranged, albumin can be low if it's a chronic cirrhosis patient or not. So all that, if it's CLD, stigmata of CLD can be there, palmar erythema, all that the flapping tremor and everything. So those are the things with hepatocellular jaundice. How about obstructive jaundice? Obstructive jaundice is when there is obstruction in the biliary tract. It can be in the common bile duct or elsewhere, where it leads to increase in conjugated bilirubin, because after conjugation from the liver, it's reaching the biliary tract, and now it's getting obstructed and can regurgitate into the blood. So there can be bile salts in the blood. There can be pruritus, right? There can be pale colored stools. Those are the things with obstructive jaundice. Here this seems like some problem with the liver, right? Because the enzymes are elevated, INR is mildly raised, ALP is elevated, bilirubin is high. So what is the likely diagnosis? And the patient has no history of alcohol also. So it can be infectious hepatitis or viral hepatitis, right? In case of alcoholic hepatitis, this AST by ALT ratio would have been 2:1 or more than 2. Right? AST would be more elevated than ALT in case of alcoholic hepatitis. Okay. Obstructive jaundice, we told it could be mainly conjugated, and AST ALT may not be such raised in obstructive jaundice. In autoimmune, you have to have some autoimmune antibodies that is elevated. This is a case of viral hepatitis. There was also another question on the similar presentation, the patient presenting with fever jaundice. The patient had history of alcohol, now presenting with raised AST ALT, and in that question AST by ALT was more than 2. In that case, you can say it is alcoholic hepatitis. There were two questions. One was to diagnose what is the likely diagnosis, and the option given was alcoholic hepatitis. Another question, similar presentation, AST more than ALT, AST by ALT more than 2. And they asked what is the mechanism. And the option was alcohol induced liver injury. Okay, so that is a different kind of questions they asked. Next, a 45-year-old woman presents with right upper quadrant pain, pruritus and jaundice. She also has xanthomas over skin. Lab investigation shows ALP markedly elevated. Deranged liver function test with a cholestatic pattern. AMA positive, anti-mitochondrial antibody positive, and ANA negative, anti-nuclear antibody negative. So anti-mitochondrial antibody with jaundice, upper abdominal, upper quadrant pain. What does it ring? It is a case of primary biliary cirrhosis, PBC, primary biliary cirrhosis. So what do you do in primary biliary cirrhosis? You can give Udiliv. Udiliv is ursodeoxycholic acid to prevent the progression and all. It's not like a treatment, it's supportive treatment. There's no role of prednisolone as a heparin or endoscopic biliary stenting. So the treatment is Udiliv or ursodeoxycholic acid in case of primary biliary cirrhosis. Remember, anti-mitochondrial antibody is positive. A 10-year-old child with known sickle cell anemia with sudden onset weakness of right upper and lower limb, difficulty in speaking for the past 1 hour. So weakness, difficulty in speaking, these are like the fast symptoms like facial deviation, arm weakness, speech abnormalities, and time. That is the thing you look for when you are trying to rule out stroke. There is no fever, trauma, seizure activity. Power is 2 by 5 in right upper and lower limb. So it's like a right hemiplegia. Cranial nerves, left human facial palsy. No signs of meningism. No, NCCT is normal, so there is no brain bleed. What is the most likely diagnosis? Why is this patient having stroke? Let's see. It's because of sickle cell anemia. Because sickle cell anemia can predispose to thrombus and embolism, right? So it is ischemic stroke, not hemorrhagic. Hence, CT came out to be normal. Transient ischemic attack, no. That you can say only if it has resolved after within 24 hours, right? Cerebral abscess, no. There is no fever, right? So it's a case of ischemic stroke due to sickle cell anemia. Next, a 68-year-old man with non-valvular AF. Presence for routine follow-up. His history includes hypertension, type 2 DM, no prior stroke or bleeding episodes, normal renal function, Child-2DS2 vascularis 3. What is the treatment of choice for stroke prevention? So in AF, there are 3 limbs of treatment of AF: rhythm conversion, rate control, and anticoagulation as and when required. So in this patient, since the Child-2DS2 score is 3, because Child-2DS2 score more than or equal to 1, you have to anticoagulate the patient. If the 1 score is because of female, you need another score as well. What are the criteria to remember? C means cardiovascular, H hypertension, A has a 2 score if it's more than 75 years, D means diabetes, S means previous ischemic event or stroke or TIA, that also has a 2 score. B means any vascular. A means age less than 75, you can give a score of 1. S means sex, that is, if it is female, you can give a score of 1. So what is the treatment of choice of stroke prevention in this patient? Aspirin alone, dual antiplatelet therapy? No, you don't give antiplatelet to prevent coagulation. You have to give anticoagulants instead. Warfarin with target INR 2 to 3 or direct oral anticoagulant. I get confused between these two because warfarin can also be given, DOSC can also be given. If it was with valvular AF, better use warfarin. But warfarin requires INR monitoring and it has side effects also. So in a non-valvular AF, you better give direct oral anticoagulant. So here, anticoagulation is mandatory. More than or equal to 1 itself you have to give, unless 1 is because of female sex. Non-valvular AF, DOAC are preferred over warfarin because of lower IC bleeding risk and no INR monitoring required. And the examples are apixaban, rivaroxaban, dabigatran, and edoxaban. These are direct oral anticoagulant. So in a newly diagnosed AF, how do you go about the treatment? If cardioversion is required or planned, then you see if it is unstable or stable. If the duration is not more than 48 hours, that means it's not a chronic AF, it's an acute AF, then you have to, if the patient is unstable, you can give cardioversion. If the duration is not known before giving cardioversion, you have to preferably anticoagulate the patient 3 to 4 weeks prior to cardioversion and continue around 4 weeks after cardioversion, right? If the patient is unstable, you can then and there cardiovert, but if the patient is stable, you have a time frame to anticoagulate the patient prior to cardioversion, you can do that, 4 weeks at least. Now, if the patient is acute, unstable, you give cardioversion and you determine the risk of thromboembolism using Chartu-DS2 VAS score. Okay, if it is more than or equal to 1, then you have to give anticoagulation with DOAC, direct acting oral anticoagulants, right? If there is no cardioversion planned, so 3 limbs of management was rhythm control, rate control, and anticoagulation. And if it's no cardioversion is planned, you see if it is a valvular or a non-valvular AF. Again, determine the risk of Chartu-DS2 VAS score. In valvular AF, you also look for one score called Hasbled score, that is the bleeding risk. And if the Hasbled score is low, you can anticoagulate. So if the Chartu-DS2 VAS score is high, you have to anticoagulate, right? And again, anticoagulation. If the patient is already on warfarin and the INR is within the range and the cost of DOIC is a concern because it's costlier than warfarin, then or EGFR is less than 30, because only apixaban is suitable in end-stage renal disease. In all those cases, you go for warfarin. In our patient, the renal function was normal and it was non-valvular AF. Then you can go for direct acting oral anticoagulants. In pregnancy, remember you better give heparin or low molecular weight heparin. Okay, then there was another question on a patient who had some cardiac illness. They are posted for some kind of a surgery. What does the preoperative workup include? That is what they ask. So in a patient with any cardiac risk, you have to do a minimum ECG and echo. Okay, 2D echo. So that is it. Transesophageal echocardiography or transthoracic, TT or TEE. Then another question was about SVT. A patient coming with SVT, I think the ECG was given. And what is the first line management? First line management is carotid massage. Carotid massage or any vagal maneuver like a Valsalva or carotid sinus massage. And if it's not resolving, what is the next step? The next step is A, B, C. That's how you remember, right? A for adenosine. If adenosine is contraindicated, then beta blocker. But both adenosine and beta blockers are contraindicated in which patients? Asthma patients. So in those patients, you straight away go for calcium channel blocker, like verapamil, right? Contraindicated in asthma. Then another question, a case of AS, aortic stenosis, but and the valve area is less than 1 centimeter square. So what is the treatment? So in AS, symptomatic patient, valve area less than 1 centimeter square, all require surgery, that is aortic valve replacement. Before doing aortic valve replacement, always do a angiography to see if there are any occluded coronary vessels, so that you can combine aortic valve replacement with the CABG if required. Next question. A 45-year-old man with progressive unilateral hearing loss for 1 year associated with tinnitus and imbalance. So there is hearing loss, tinnitus, imbalance. Otoscopic examination is normal. Rennie test is positive. Weber lateralizes to normal ear. So this we need to discuss in detail about Rennie and Weber. So what is Rennie and what is Weber's test? You know how to do the test, right? What is Rennie? Rennie's test is when you're putting a vibrating tuning fork first over your mastoid process. Once the vibration stops, you place it near your ear, right? Usually the air conduction would be better than bone conduction. So you will still hear the vibration even after it stops from your bone. That is a Rennie test, right? And Rennie test positive means air conduction is normal, air conduction more than bone conduction. That is what Rennie positive means. You have to know what this positive and negative means, okay? So Rennie positive means what? That is a normal scenario. That is air conduction is better than bone conduction. And this can happen in two scenarios. One is when the patient has a normal hearing, or if the patient has a sensory neural hearing loss. Okay, two scenarios. Now, when will be Rennie negative? When is Rennie negative? Rennie negative means the opposite. Bone conduction would be better than air conduction. And what is that? That is a conductive hearing loss. Okay, this is a conductive hearing loss. These are the two scenarios with Rennie. How about Weber? What is Weber? You are taking a tuning fork, vibrating it, and placing it over the central part of your forehead, just above the glabella you can keep, and you're seeing if you're hearing that vibration, feeling that vibration equally in both ears. If equally in both ears, it's called centralized. So Weber can be centralized or lateralized. If it's centralized, it's normal. If it's lateralized, there are two cases. It can be lateralized to normal ear or worse ear. Worse ear. If it's normalized to worse ear, then it's a case of conductive hearing loss. If it's lateralized to the better hearing ear, then it's a case of, or opposite ear, that is what we say, that is a case of conductive hearing loss. Now let's analyze this situation. What is happening? Rennie test is positive, okay, and he has unilateral hearing loss. Weber lateralizes to normal ear. Suppose unilateral, they didn't mention the side. Let's suppose that is a right side. So hearing loss over the right side. So Rini test is positive on the right side, which means bone conduction, air conduction more than bone conduction on the right ear. That means it's either normal or sensory neural hearing loss. Since there is hearing loss, we'll consider it as sensory neural hearing loss over the right side. So this seems like a case of right sensory neural hearing loss. Now look at the Weber. Weber lateralizes to normal ear. Weber lateralizes to normal ear. Weber lateralizes to the opposite ear in case of sensory neural. Here it is sensory neural hearing loss. Okay, normal ear in case of sensory neural hearing loss, and worse ear in case of conductive hearing loss. So it lateralizes to normal ear. Here normal ear is left ear. That means opposite ear. So that is again a case of right sensory neural hearing loss. So here it is a right sensory neural hearing loss. What can be a sensory neural hearing loss? It can be a vestibular schwannoma, especially the patient has tinnitus imbalance, or a Meniere's disease. It can be retrocochlear or cochlear, right? So what do you do to confirm? Do you do a pure tone audiometry? What does pure tone audiometry give? It can give the diagnosis of whether it's sensory neural or conductive. That you already know from Rini and Weber. Now you have to confirm the diagnosis. So pure tone audiometry nowhere confirms this diagnosis. It only gives an idea whether it's sensory neural or conductive or both, like mixed hearing loss. CT scan of temporal bone, MRI brain with gadolinium. For a vestibular schwannoma or acoustic neuroma, what is more sensitive? Is it MRI or CT? It's MRI, right? How about Vera? Vera is not, again, a very confirmatory diagnosis for acoustic neuroma. It can give a diagnosis of cochlear versus retrocochlear. It's like a wave-like response. You can see the absence of wave 5, which is mainly the one which is affected, right? So this is it. So here in this case, we do an MRI with gadolinium to confirm the diagnosis of acoustic neuroma or vestibular schwannoma, which is a type of sensory neural hearing loss. Now, this was what I was talking about, the Rini and Weber. Rini, normally it is air conduction more than bone conduction. That is Rini positive. It can be positive also in, that is a false positive in sensory neural hearing loss as well. Rini is negative when bone conduction is more than air conduction. That is a case of conductive hearing loss. Weber, usually it's centralized or heard in the midline, but it can be lateralized in two cases. Either it can be lateralized to the normal ear, which is a better hearing ear. That is a case of sensory neural hearing loss. And Rini can be, Weber can be lateralized to the worse ear, that is poor ear, which has a problem, and that is a case of conductive hearing loss. Okay. Okay, then there was another question on BPPV. The description was given that the patient was having vertigo, especially positional when they are rolling over from bed or something. And we are asked, what is the treatment? So for treatment, we do Epley's maneuver, and for diagnosis, it is the Dix-Hallpike maneuver. You can remember D for diagnosis. So diagnosis, it is the Dix-Hallpike maneuver. Okay. There is otolith in the semicircular canal, and we are actually doing a repositioning maneuver when we are doing the Epley's, right? Here in this picture, you can see the description of how we do the Epley's. The overall description is not required. Usually they ask what is the maneuver that we use. Mainly it is the posterior canal or the horizontal semicircular canal. First the patient is sitting upright and the head is rotated 45 degree. Then the patient is passively forced down into the supine. Head is held 30-degree neck extension. Okay, then the patient remains in that position for 1 to 2 minutes. Then the head is rotated 90-degree to opposite direction again. They are kept in that position for 1 to 2 minutes. Then the shoulder is rotated. Uh, the patient rolls into shoulder, rotating head 90 degrees. Okay, and they are looking downward at 45-degree angle, and they remain in that position for 1 to 2 minutes. And the patient is slowly brought upright, and the sitting position is held for another 30 seconds. This is how you do a bleed maneuver. This is a canalith repositioning maneuver. Dix Hallback is for the diagnosis. You will sit with your head turned 45 and eyes wide open, and then you will slowly lean back. Okay, and we'll stay there for 1 to 2 minutes, and the provider will check for nystagmus. Okay, that will be diagnostic. Coming to next question, a 24-year-old man with chronic diarrhea, abdominal pain, unintentional weight loss. Okay, chronic diarrhea, abdominal pain, unintentional weight loss, and occasional blood in stools. Symptoms worsen during period of stress but do not completely resolve. There is mild anemia, raised CRP, elevated fecal calprotectin. What is the most likely diagnosis? So when you see chronic diarrhea in a young patient, it can be IBS or IBD. That is your most likely diagnosis. Or malabsorption syndromes like you have topical sprue, you have celiac disease, all those things, right? These are the common differentials. Now, this thing that they give, that is elevated fecal calprotectin, is to differentiate between IBS and IBD, that inflammatory bowel disease and irritable bowel syndrome. Irritable bowel syndrome is more like benign. It's not a great pathology. There can be change in frequency of the stool. It can be diarrhea predominant or constipation predominant, and it can be associated with stress also. Okay, but blood in stool, elevated fecal calprotectin, raised CRP, anemia, everything points towards a more serious diagnosis of IBD, that is inflammatory bowel disease, which can be ulcerative colitis or Crohn's disease. Okay, so in this case it can be Crohn's disease because the fecal calprotectin was high. Okay, so this is a case of Crohn's disease. Other options, IBS, it is usually inflammatory, irritable bowel syndrome. Usually it's symptomatic management that can worsen with stress and all. About celiac disease, it is gluten-free diet. The management is gluten-free diet. And the lactose intolerance, it's usually intolerance to lactose, right? And you have to give a lactose-free diet. But here it's elevated fecal calprotectin with blood in stools and diarrhea. It can be in inflammatory bowel disease like Crohn's disease. Next question. A 55-year-old man undergoes routine colorectal cancer screening. He is asymptomatic, but father was diagnosed with colorectal cancer. His fecal immunochemical test is positive. What is the next best investigation? So, what do? A flexible sigmoidoscopy, CT abdomen and pelvis, colonoscopy, and serum CA level. So there is a familial history of colorectal cancer, and if it is positive, then you have to do a colonoscopy. Okay, colonoscopy should be done. Usually it is done 50 years and above, and if there is family history, then you have to do it 10 years prior to the age of diagnosis of the family member, if it's a first degree relative. Okay, and then every 10 years you repeat. Next question. A 3-year-old child diagnosed with iron deficiency anemia and treated with oral iron therapy for 3 months. On follow-up, the child is asymptomatic. Investigations now show hemoglobin is normal. What is the next best step in management? So do you stop iron therapy immediately after 3 months, or repeat serum ferritin now, or continue iron therapy for another 3 months, or no further treatment or follow-up is required? What do you think? So in iron deficiency anemia, you give iron for 3 months, and when the hemoglobin comes to be normal, you have to continue iron therapy for another 3 months, and then you have to decide on stopping. Okay, that is it. So continue iron therapy for another 3 months, because the protocol is treat until HB is normal, along with another 3 more months. And there were questions about iron deficiency anemia, like what is the diagnosis. They have given a low MCV, low MCH, and then they ask what is the diagnosis with differentials like iron deficiency, thalassemia, and all. Right? So it is iron deficiency anemia. That question, it was iron deficiency anemia. In iron deficiency anemia, what else can you see for RDW? That is red cell distribution width. It can be more than 15 if it's a nutritional anemia like iron deficiency anemia. Then thalassemia is also microcytic hypochromic anemia. So how do you differentiate between iron deficiency and thalassemia? It's by an index called Menzer index. Menzer index is MCV by RBC, and that can be less than 13 in thalassemia, more than 13 in iron deficiency anemia. There was another question, I think 2 or 3 questions on aplastic anemia. One was to diagnose. It was a pancytopenia, and they asked for the diagnosis, so it was aplastic anemia. Then they given a scenario of aplastic anemia and asked what is the next best step in investigation. So you have to confirm aplastic anemia by doing a bone marrow biopsy. You can either get a dry tap or completely acellular hypocellular picture in the bone marrow. That will confirm the diagnosis of aplastic anemia. So this slide is showing the differential diagnosis of anemia. You can have either microcytic anemia, normocytic anemia, or macrocytic anemia based on MCV. Right, MCV less than 80 is microcytic, 80 to 100 is normal, and more than 100 is macrocytic. Microcytic anemia, usual differentials are iron deficiency, thalassemia, anemia of chronic disease due to increase in hepcidin, because that is like the inhibitor of iron absorption. Sideroblastic anemia, lead poisoning. Then normocytic can be hemolytic or non-hemolytic. Hemolytic is due to the hemolysis. It can be intrinsic, like hereditary spherocytosis, PNH, paroxysmal nocturnal hemoglobinuria, G6PD deficiency, especially when you give fava beans or drugs like quinidine, right? Primaquine, which is an antimalarial drug. Okay, then pyruvate kinase deficiency, sickle cell anemia, and HPC disease. Extrinsic, it is microangiopathic hemolytic anemia, which is your MAHA, that is TTP-HUS and DIC. Then macroangiopathic hemolytic anemia and autoimmune hemolytic anemia. Non-hemolytic again can be iron deficiency, which can be like usually iron deficiency is microcytic only. Anemia of chronic disease can be microcytic or normocytic. CKD, aplastic anemia. Then macrocytic can be 2, megaloblastic and non-megaloblastic. Megaloblastic is usual vitamin B12 deficiency, folate deficiency, and copper deficiency or otic aciduria, and drug-induced like allopurinol. In vitamin B12 deficiency, you have the sensory symptoms like subacute combined degeneration, your peripheral neuropathy. So in a megaloblastic anemia, if you replace only folate, the anemia will resolve, but the sensory and neurological symptom will worsen. So you have to give vitamin B12 also. Non-megaloblastic, it can be alcohol use disorder, liver disease, and diamond blackfan anemia. This is like the usual differentials. I've added this slide from hematology because there were many questions. There were, I think, questions regarding CML, the diagnostic criteria, what is it like the next best step investigation. And I think there was CLL and non-Hodgkin's lymphoma. So I've just made a table, added a table so that you understand how to differentiate. So first thing you look is always the age of presentation. ALL usually it's in children, and the classical age of presentation is 2 to 10 years. Less than 2, more than 10, it's going to be having a worse prognosis, grave prognosis. How about CLL? CLL is usually in adults. And AML, again in adults. CML, it's rare in children, to 20 to 50 years adult. Okay, so usually young children first think of ALL rather than any other differentials, think of ALL. Then the peripheral smear picture. In acute versus chronic, what is the difference in acute versus chronic? You get all the different kinds of the lineage series, all the different kinds of cell in chronic. In acute, it's usually one kind of cells. Okay, that is the main difference. And in CLL, since there are so many cells, you can see something called smudge cells. These are like the artifact which is created during this lipofiltration. They are called smudge cells, right? So ALL, it can be chromosomal aberration resulting in abnormal transcription factors that affect the development of B cells or T cells. So it is either immature B or T cell. And what you have, it's mainly the CNS manifestations. There can be depressed marrow function. Okay, there the CBC result can be anemia, thrombocytopenia, and WBC count will be more than 30% lymphoblasts. That is your diagnosis. Okay, so in a young child presenting with a peripheral smear of so much of blasts and some anemic features with thrombocytopenia, think of ALL. How about CLL? Chronic lymphocytic leukemia. Usually in adults, peripheral smear showing smudge cells, and they are usually having hepatosplenomegaly, but CML has massive splenomegaly rather than CLL, and the platelet count can also be low. In AML has actually many types. In the most one of the most common varieties M2, AML M2, but AML M3 is APML, that is acute promyelocytic leukemia, which usually presents with DIC. Okay, and they have O roads. And in APML, these O roads are like road-like things in the cytoplasm, and O roads are combined together, and that is called a fagot cell. Okay, and they have anemic symptoms, spontaneous bleeding, fatigue and ecchymosis, especially in the APML. That is acute promyelocytic leukemia, which presents with DIC. What is the treatment of APML? It is all trans-retinoic acid. Okay, because the translocation is also related to PML RARA. And it can present with neutropenia, thrombocytopenia, and more than 30% myeloblasts. Okay. In acute leukemia, there will be more blasts. And in CML, usually there are different kinds of cells that you can see together, and the classical mutation, the most famous pathognomonic, is the Philadelphia chromosome. That is BCR-ABL translocation. BCR-ABL translocation 922, BCR-ABL. And this is having insidious onset. There is massive splenomegaly, anemic symptoms, WBC can be more than 50,000, or in symptomatic case it can be even up to 1 lakh. Increased eosinophils as well as basophils. This is also one clue that is saying it is CML. So massive splenomegaly in an adult, peripheral showing lots of cells, and Philadelphia chromosome. So what is the next step in investigation? It's going to be the BCR-ABL translocation, which you can diagnose using FISH. How about in CLL? You do a flow cytometry. This was also in the question, like what is the next step in investigation? The clinical picture was that of CLL. Okay, so this is about leukemias in general. So how do you work up symptoms plus hepatosplenomegaly? You do a first line like CBC, peripheral smear, and blast cells on smear. Then you look for either it's a lymphoid series or a myeloid series. If it is lymphoid, again, is it acute or chronic? Okay, then do a bone marrow biopsy. In acute, you will always see more than 20% lymphoblasts, then that is ALL. Then you can look for Philadelphia chromosome. Philadelphia chromosome is not pathognomonic of ALL, but it is showing the prognosis in ALL. In ALL, if Philadelphia chromosome, which is the BCR-ABL 922 translocation is positive, it is going to have a grave prognosis, right? Now, if it's a chronic, then it can be either a hairy cell leukemia, or if there are smudge cells, you do a flow cytometry and then you look for the CD markers. Then you can diagnose CLL, because you can then decide on the treatment also. If it's myeloid series, again, more than 20% blast, it's going to be acute. So acute myeloid leukemia. Do a bone marrow biopsy. If it's myeloblast, it's AML. If it's atypical promyelocytes, it's APML. That is acute promyelocytic leukemia, which is AML M3. So that your treatment becomes ATRA, or transretinoic acid. Okay. Then, if it's chronic, WBC more than 1 lakh, you can do a FISH or flow cytometry to look for Philadelphia chromosome, translocation 922 BCR ABL, then you can diagnose CML. Okay, look for blast crisis also to decide on the treatment. So this is going to be the differential and the investigation and treatment. Treatment, mainly you have to remember of the APML, which presents with DIC, and you treat with ETRA, all transretinoic acid. Then there was a question on APLA, like there was a presentation where the patient had arterial and venous thrombosis, and it was they were mentioning towards, pointing out towards APLA, and what is the investigation, and they give beta-2 glycoprotein. So there are 3 antibodies: beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant. Beta-2 glycoprotein you can do, and APLA markers can be positive also in SLE, right? And it can have both arterial and venous thrombosis, recurrent miscarriages in a female. Also think about APLA. Next question: a 19-year-old woman presents with recurrent episodes of epistaxis and menorrhagia since adolescence. There is no history of trauma or anticoagulant use. Okay, so there is epistaxis and menorrhagia. So bleeding manifestation in a young female or adolescent woman. Since adolescence also there has been epistaxis. No history of trauma or anticoagulant use, family history of significant for similar bleeding episodes. So it can be an autosomal dominant in female relatives. So it can be autosomal dominant. Platelet count is normal, bleeding time is prolonged, prothrombin time is normal, APTT is mildly prolonged. So there are two things which are prolonged: bleeding time as well as APTT. If it was simply APTT, you always think about the coagulation disorders like your hemophilia. But since bleeding time is also prolonged, what is it indicating? The most common bleeding disorder, that is von Willebrand disease, which is having an autosomal dominant presentation, autosomal dominant inheritance. Okay, why bleeding time is prolonged? Because it's a von Willebrand factor, right, which is helping in aggregation of the platelet and or adhesion of the platelet, to be precise. And how about APTT? Because it is also a carrier of factor 8, so APTT is also prolonged. And what is the treatment? You give desmopressin, right? In acute bleeding presentation, you may have to give PCC or FFP, but in otherwise you will give desmopressin. Why not factor 8? Factor 8 alone would be insufficient in this case, because in factor 8 or hemophilia, bleeding time would be normal. Not mixing study. Mixing study is again for deficiency. Start desmopressin therapy before the diagnosis, you can't start treatment. So you have to diagnose first. So do a von Willebrand disease workup and then decide on the treatment. Then there were questions from pharmacology. I've not added the clinical scenarios per se. I'll just describe the questions and how it was. There was a presentation of digoxin toxicity. The patient was already having some cardiac disease and they were started on treatment, and now they're having some non-specific symptoms. And digoxin toxicity also can have like yellowish discoloration of the vision, uh, and some other presentations. But here it was not specific which drug was the cause. They asked from the options, the digoxin toxicity was the most likely. Then about I think high cholesterol and what do you start the patient on? It's the statins. In a patient or with CKD stage 3 on multiple drugs, now which recommendation would you follow regarding their routine medication? So the patient was on metformin. So in CKD, when it's stage 3 and beyond, you better avoid metformin for the risk of MALA, metformin associated lactic acidosis, which can have a grave outcome in the patient. So you stop metformin, okay? And there'll be so many drugs which requires adjustments in the dose in a CKD patient. Then I think I don't remember which drug. It was not spironolactone, but some from the family which would cause uh, potassium levels. So they asked what is required when you start the patient on this drug. So potassium monitoring would be required. When you're giving furosemide, for example, it can cause hypokalemia. So when you're giving furosemide along with digoxin, hypokalemia can increase the digoxin toxicity. So you have to monitor the patient for hypokalemia when you're giving both the drugs together. Okay, so those are the things that you should keep in mind, especially from pharmacology. Then a description of absenteeism was given, that the child was staring for a long time, abnormal blinking episodes. They were daydreaming like episodes. So what is the treatment? So it is ethosuximide. EEG can show 2 to 3 hertz spike and wave pattern, and the treatment is ethosuximide. Another question, rheumatoid arthritis. The patient is already on methotrexate, but they have persistent symptoms. What is the next step? So option will start biological DMARD, drug modifying agents, again rheumatoid arthritis, rheumatic disease. Another question was a description of non-ulcer dyspepsia. They did disclose non-ulcer dyspepsia. What is the treatment? So you give PPI, proton pump inhibitor. Then another question on like I don't remember if it was like a match the following something, like which agent cause which. So benzene can cause aplastic anemia. Okay, I think the description of aplastic anemia, clinical scenario of aplastic anemia is given, and they asked which agent would cause this. So leukemia aplastic anemia can be seen with benzene exposure. Okay, next question. A 42-year-old woman presents to wellness clinic for routine evaluation. She has BMI of 33. Non-case of type 2 DM, well controlled on OHA, no features of other endocrine disorder. Physical examination is unremarkable. What is the most likely contributing factor to her obesity? So she's having type 2 DM, but she's well controlled on OHA. Now she's having high obesity, high BMI. What would be the factor? Is it hypothyroidism, Cushing syndrome, lifestyle factors, genetic syndrome? So they did mention there are no other endocrine disorders, no symptoms suggestive of endocrine disorder. So what is the first thing that comes to your mind? It's lifestyle factors. Rule out that. Try modifying their lifestyle factors and then see if it is responding. That's lifestyle factors. Then there was a question on psoriasis, like what is the likely diagnosis? They have given a complete description of the dermatological manifestation. There is a lesion, which is scaling, and on the exposed extensor aspect, I think on the knee it was mentioned. And what is the likely diagnosis? So it was psoriasis. Next question, a 45-year-old woman presents with heel pain for 3 months. Worse with the first few steps after prolonged standing. Pain improves slightly with walking but worsens again by the end of the day. There is localized tenderness over the medial calcaneal tubercle. No history of trauma, X-ray of the foot is normal. Next best step in management. So this heel pain is more likely the plantar fasciitis. Okay. And what is the treatment? Next best step, local corticosteroid injection, physiotherapy with stretching exercise, heel pad or silicone heel cushion, surgical plantar fascia release. So local corticosteroid, that is for assistant cases. Surgical plantar fascia release also is like the final resort. Heel pad, silicone heel cushion can be symptomatic management, but the most likely answer is physiotherapy with stretching exercise. So this is a diagnosis of plantar fasciitis. You do physiotherapy with stretching exercise. There was a description, a scenario, and they had mentioned like there is a biceps reflex is abnormal, and the C6 area, the dermatomal distribution, which is like the lateral aspect of the forearm, along with the thumb and the index finger. Their sensations are affected. So, what is the likely diagnosis? So, this is going to be C6 radiculopathy. So, go through the dermatomal distribution, go through the reflex, and what are the root values, because that is very very important. They can ask from any site. This time it was C6 radiculopathy. Okay, so C6 radiculopathy affect all this. Reflex like brachioradialis reflex can be affected. Muscles like extensor carpi radialis action, brachioradialis can be affected. And the sensory distribution over the lateral forearm along with the thumb and index finger can be affected. Next question, a 54-year-old man with known case of CLD, chronic liver disease, presents to emergency department with hematemesis and melena. He is tachycardiac and hypotensive. Examination shows pallor and stigmata of chronic liver disease. What is the most appropriate immediate management? So this is a case of CLD now coming with hematemesis and melena, that is upper GI bleed. Maybe mostly varicose bleed because they have CLD. They are tachycardic and hypotensive, especially from the blood loss. They show pallor and stigmata of CLD. What is the immediate management? So they are asking about the immediate management case of a varicose bleed. Is it emergency endoscopy with band ligation? Start IV octreotide. Start proton pump inhibitor infusion. Insert Seng's taken Blackmore tube. So you comment the answer in the comment box. We'll discuss from this question onwards in the next video. That is going to be the last of this recall series of Chan 4 exam of EMREE. Thank you so much and all the best for all of you who are preparing for the exam.